This is part 2 of a series on neonatal pharmacology. This section will focus primarily on specific drugs related to anesthesia. As with the first part, this session is intended for residents who will occasionally take care of children, especially neonates. The sessions are not aimed at a level for those who are or wish to be pediatric anesthesiologists. One final caveat, the lecture series is on neonatal pharmacology. For the most part, I do not address issues for older children. I have no conflicts of interest to disclose. This section begins with agents used for induction of anesthesia. Next is a discussion of drugs used for neuromuscular blockade, followed by reversal agents. The section concludes with opioids commonly used in neonates. The volume of distribution of propofol is larger in children than in adults. This will obviously necessitate a larger dose to achieve a comparable level of anesthesia. These numbers represent the ED50 for loss of the lash reflex. Essentially, no work has been done to determine the ED50 of propofol in neonates, but it is evident that infants have a higher ED50 compared to children over the age of 1 year. One study reported that a dose of 2.5 milligrams per kilogram was necessary to permit tracheal intubation in neonates, but the exact doses were not provided. Clearance, which is limited by hepatic blood flow, is about 50% of adult values in term neonates and only about 20% of adult values in 30-week preemies. The decreased clearance, coupled with administration of a larger dose for induction of anesthesia, obviously results in a prolonged duration of action. No specific studies have been done in neonates, but it's logical to assume the hemodynamic and respiratory changes that occur in older children will also occur in neonates. There are, however, case reports of severe hypotension, bradycardia, and hypoxemia after a single induction dose of propofol. In at least one case, the dose was only 1 milligram per kilogram. In these circumstances, resuscitation was described as, quote, extremely difficult, unquote. Although multiple etiologies have been proposed, there is no definitive explanation. The author of a comprehensive review on the subject stated, quote, propofol carries a finite risk for bradycardia with a potential for harm, unquote. Like propofol, ketamine has an increased volume of distribution and a decreased clearance in neonates. Etomidate also has a decreased clearance in neonates. Adrenal suppression following a single induction dose of etomidate is of concern in adults. With regard to pediatric patients, a single study involving 31 children with meningococcal sepsis who required intubation demonstrated lower cortisol levels and higher ACTH levels in the 23 children intubated using etomidate. Remember that meningococcal sepsis is associated with the development of Waterhouse-Friderichsen syndrome, that is, hemorrhage into the adrenal glands with resultant adrenal failure. Now on to neuromuscular blocking drugs and reversal agents. As shown here, an immature postjunctional acetylcholine receptor consists of 5 subunits. One beta subunit, one gamma subunit, and one delta subunit. This contrasts with a mature receptor which has an epsilon subunit instead of the gamma subunit. In response to acetylcholine, a fetal receptor stays open longer. This allows for a greater influx of sodium through the channel and a longer duration of depolarization. In addition, acetylcholine reserves are depleted more quickly in neonates than in older children or in adults. This curve shows the age-based dose-response curve to vecuronium. Although the data are for vecuronium, the curves for the other non-depolarizing neuromuscular blocking drugs are essentially parallel. The neonates' increased sensitivity to vecuronium is clearly evident. Two theories have been advanced to explain this. The first is the fact that, as previously noted, neonates deplete their acetylcholine stores more quickly. The second is that, based on synergism studies, non-depolarizing neuromuscular blocking drugs occupy only one of the alpha receptor sites in neonates. This contrasts with mature receptors, in which case the drugs occupy both alpha subunits. Whatever the reason, neonates are more sensitive to these drugs. Remember also, however, that the increased total body water of a neonate leads to a greater volume of distribution for neuromuscular blocking drugs. This necessitates a larger dose to achieve the desired effects. Presumably you remember the difference in types of muscle fibers. Type 1 are slow twitch fibers which are resistant to fatigue. Type 2 fibers, both 2A and 2B, are more susceptible to fatigue. This is relevant because the number or percentage of type 1 fibers in both the diaphragm and the intercostal muscles increase with age. The interesting thing is that type 1 fibers are more sensitive to neuromuscular blocking drugs, so the decreased number of type 1 fibers in neonates is actually something of a protective mechanism. Remember also that neonates are less able to tolerate an increased respiratory load than older children or adults. Neonates are resistant to the effects of succinylcholine. The estimate is that 1 milligram per kilogram in an infant is necessary to produce a degree of blockade comparable to 1/2 milligram per kilogram in an older child. Dosage recommendations are variable. It has been described that 2 milligrams per kilogram does not produce satisfactory intubating conditions in all children, and that a dose of 3 milligrams per kilogram is necessary to achieve 85% depression of the twitch response. Compared to older children, in neonates the dose requirement is larger, the onset time is shorter, and the duration of action is longer. There are sporadic reports of prolonged neuromuscular blockade in neonates following administration of succinylcholine. Most of these cases are due to atypical pseudocholinesterase. I have personal experience of that when a 4-week-old child undergoing a pyloromyotomy required over 4 hours to recover from a single dose of 1.5 milligrams per kilogram of succinylcholine. In the non-anesthesia literature, this problem is often incorrectly described as a deficiency of pseudocholinesterase. Although succinylcholine can be administered via the intramuscular or intralingual route, that is rarely, if ever, necessary in a neonate. The elimination half-life of Atracurium is the same for term neonates as for infants. Likewise, the steady-state concentrations in plasma producing 50% neuromuscular blockade was the same in neonates and infants. This graph, shown earlier in this presentation, demonstrates a lower ED50 and ED95 in neonates compared to older children or adults. Studies on neonates and infants have demonstrated that the duration of action for vecuronium is approximately 50% longer in neonates, 59 minutes after 105 mics per kilogram, than in children, 37 minutes following the same dose. This study, performed in a neonatal intensive care unit, looked at the effect of a 0.5 milligram per kilogram of rocuronium for elective reintubations in neonates and premature infants. Another study looked at infants and older children and determined the ED95 to be 0.26 milligrams per kilogram for infants and 0.34 milligrams per kilogram for older children. These data are consistent with the findings for vecuronium, which showed that neonates required a smaller dose than older children. As shown in this table, Reversal of neuromuscular blockade by neostigmine takes almost twice as long in neonates as it does in young children. Sugammadex, 4 milligrams per kilogram, has been used to successfully reverse rocuronium-induced neuromuscular blockade in neonates. There is extremely wide inter-individual variability in both the pharmacokinetics and pharmacodynamics of morphine. Clearance, which is generally limited by hepatic perfusion, is substantially reduced in neonates, especially preemies. This accounts, at least in part, for the prolonged duration of action in these patients. It also explains why the dose requirements are reduced in neonates receiving continuous infusions for postoperative analgesia. Compared to older children and adults, neonates also appear to have increased respiratory depression following morphine administration. It's not clear if this is due to decreased clearance with the resultant accumulation of drug and active metabolites, increased permeability of the blood-brain barrier, or lack of maturation of the respiratory centers. Fentanyl clearance is significantly impacted by gestational age, but is within approximately 20% of adult values for neonates at term. Notably, at 3 months of age, term infants have a clearance that is more than 50% greater than the clearance in adults. At almost 6 liters per kilogram, in term neonates, the volume of distribution is almost 4 times that of adults, in whom the volume of distribution is 1.6 liters per kilogram. Although not applicable in the OR, the fentanyl infusion rates necessary to achieve a similar level of sedation vary by a factor of 10 in critically ill children. In summary, when administering propofol, the larger volume of distribution is the explanation for why a larger dose is necessary to achieve a comparable effect. Coupled with the larger induction dose, decreased clearance results in a longer duration of action. The situation with non-depolarizing neuromuscular blocking drugs is more complex. Clearly, the increased total body water results in an increased volume of distribution. However, the increased sensitivity of the immature postjunctional acetylcholine receptors more than offsets the increased volume of distribution, resulting in increased sensitivity of the neonates to non-depolarizing neuromuscular blocking drugs. The time to the onset of action of neostigmine is significantly increased in neonates. Sugammadex has, however, been successfully used in this patient population. Both the pharmacokinetics and the pharmacodynamics of morphine demonstrate significant inter-individual variability. Thank you for taking your time to review this presentation. I hope you found it helpful.